Welcome everyone to this relatively brief presentation regarding de Quervain's Tenosynovitis. My name is Mr. Niall Lotvi. I'm an orthopaedic registrar based in Birmingham and will be happy to leave my email at the end of the presentation for anyone to contact me about any questions in the presentation. So if we start with the first slide, and if someone were to give a definition for de Quervain's Tenosynovitis, it's a relatively brief one sentence to explain that it's a stenosing tenosynovial inflammation and it's located in the first dorsal compartment of the wrist. Now, if you think back to your first and second year anatomy, you'll recall that in the first dorsal compartment or the first extensor compartment of the wrist, you have the tendons for abductor pollicis longus, that's APL, and extensor pollicis brevis, EPB. And again, as the names suggest, they both abduct and extend the thumb. So if we are to have a look at the demographic of people that were to get this condition, we can split them up into high-functioning relative athletes that overuse a specific movement, particularly golfers or racket sport players, and a second group of people, including postpartum women and those with risk factors such as diabetes. It's still most frequently seen secondary to overuse, and that will be one of the factors that you'd need to go into in your history taking. If we move on to the second slide, symptoms are quite specific to this condition. Patients will normally describe a few weeks or potentially months of worsening pain, particularly on the radial aspect of the wrist. This pain is often exacerbated or made worse by the activity that instigated the pathology in the first place. If we were to use the new mother in this situation, picking up her infant would often cause onset of this pain. Similarly, the keen golfer would have pain on initiation of his swing. Conversely, they will also let you know that resting the hand or not performing aforementioned activities normally helps with pain. Examination of these patients tends to be quite painful, so you have to be very careful. Direct palpation of the area can bring about the pain, but there is a very specific eponymous test that you can perform that almost always causes reciprocation of the pain that the patient is feeling. This test is called Finkelstein's maneuver. If you ask the patient to make a fist with their thumb clenched within it, and then slowly ask them to deviate the wrist towards the ulnar side, this will often reciprocate the pain on the radial aspect of the wrist just over the first dorsal compartment. Once again, be very mindful to not overly ulnar deviate the wrist, as this can be extremely painful. If we move on to the fourth slide, this pathology very nicely demonstrates that not every disease process requires multiple investigations. Your history-taking skills and examination should normally suffice in ruling in de Quervain's Tenosynovitis. In the context of trauma, if you are concerned about any deeper pathology, including scaphoid fractures or distal radius injuries, then a plain film radiograph may be indicated. Similarly, if the pain is more diffuse or generalized, particularly in an elderly patient, you may want to rule out osteoarthritic disease. If we move on to the fifth slide and the management of this troublesome pathology, you can see, as with most surgical conditions, the treatment is split into non-operative and operative management. In particular, the non-operative forms of management can be deferred for those patients presenting with their first episode of flare-up. This can be the new mother, for example, who may benefit from splinting of the wrist with education towards how to alter her activity and position her hand differently whilst picking up her infant. In addition to this, simple analgesics, such as non-steroidal inflammatory medications, which include ibuprofen, may be of benefit. In those patients that have had unsuccessful conservative measures, then we may choose to move to a slightly more invasive procedure in the form of corticosteroid injection. This injection is delivered directly into the first dorsal compartment. This is a clinic procedure and does not necessitate the use of imaging in order to be performed. If you have not had the opportunity to observe one of these for yourself, I would highly recommend it. Patients will often feel significant relief over the following 24 to 48 hours. Of course, the corticosteroid injection is not performed on its own, and it's important to continue with the conservative management mentioned prior. Unfortunately, a select group of patients will continue to have symptoms, particularly those that are unable to alter their activities. In these refractory patients, you may consider surgical intervention in the form of a surgical release of the first dorsal compartment. This will involve a small incision on the radial aspect of the wrist, directly overlying the first dorsal compartment where the tendons are lying. Following complete release, the tendons are no longer impinged upon, and symptoms usually resolve in the coming weeks. To summarize, de Quervain's tenosynovitis is a stenosing tenosynovitis of the first dorsal compartment. It can be quite debilitating, particularly for those patients that are unable to alter their activities. And as always, with most surgical conditions, there are non-operative and operative measures to take. Thank you very much for listening, and once again, my name is Niall Lotfi, and should you have any questions, feel free to email me on niallotfi@nhs.net.